Okay, good morning, everyone. We have 55 of you in the room right now. We're going to go ahead and get started. Just a quick housekeeping note before we turn it over. If you have any technical questions, please use the Q&A so those can be attended to. But if you have questions for the speakers, feel free to enter those into the chat and we will keep you engaged with our speakers. With that, I'm going to turn it over to Janice Connellan.
Good morning. Welcome to the California Campaign to Counter Childhood Adversity. We shorten that to 4CA, and our webinar on the state and federal outlook for preventing, screening, and treating trauma and ACEs. I'm Janice Connellan with Children's Defense Fund California, and I'm co-hosting this webinar on behalf of 4CA with my colleague, Kelly Hardy from Children Now. This is the second webinar in a two-part series, and I'm going to turn it back over to Danelle, and she's going to talk about the first webinar.
Good morning, everyone, and I forgot to introduce myself. I'm Danya, and my name is on the screen. My name is Danielle Prince, and I am the community facilitator for the Bay Area with ACEs Connection. For our first webinar, we had Elisa Nicholas talking to us about some of the experiences especially during these strange times of COVID. What she was experiencing at the clinic level. And we had Lynn Ann Svensson, who spoke about the experiences of working directly in public health and being part of that first response. And then we had Flojan Kofer giving an overview of kind of what was going on with the state in terms of a structural response to the situations caused by COVID that just exacerbated existing inequalities. We have a recording of that webinar. I'm gonna put a post shortly in the chat to a blog which recaps and summarizes that webinar, and it also includes a link to the recording. So I'll do that shortly.
Great. Thanks, Danelle. This second webinar will set the stage for new legislation and planning for 2021. Our speakers are prepared to give us an overview of the state and federal legislative context during this very unusual year. Our speakers will discuss actions for California advocates who are working to advance policy to support children to overcome adversity and build resilience in 2021. So our speakers today will be Dr. Dana Long, a pediatrician at UCSF Benioff Children's Hospital, Oakland, Kimberly Chen, a consultant with the California Senate Health Committee, Elisa Wen, who's with the California Senate Budget Committee, where she's the K-12 education consultant, Lena O'Rourke, who's here with us on behalf of Futures Without Violence, will provide a federal perspective, and Erin Gable, who's the education consultant for the California Assembly Budget Committee. Our format today will include a brief opening from each speaker, followed by a structured Q&A, and lastly, we'll open up the Q&A from our audience today. So please just go ahead and start writing your questions in the chat. And with that as an opening, I'd like to welcome our first speaker, Dr. Dana Long.
Good morning. I'm so pleased to be here with everybody today. I realize that for many of us that are here, particularly in Northern California, we are being confronted with yet another fire in addition to COVID and the ramifications of this pandemic. And so I just want to say that something that's inspiring me today is being able to be on this call with all of you. So thank you for the introduction, Janice. My name is Dr. Dana Long, and I am the co-director for our Center for Child and Community Health at UCSF Benioff Children's Hospital, Oakland. I am also one of the principal investigators of the PEARLS tool, which we will talk about, which is the tool that's being incentivized across the state of California in order to screen kids for adversity, trauma, and social determinants of health. So I acknowledge that we are in the midst of unprecedented times. I have my cell phone on my nightstand as I'm getting all these evacuation orders. I lived one county over from Sonoma County, and we've never experienced anything like this before. That we are all holding a multitude of feelings at the same time, and that every day we have to be able to find the joy and the gratitude. That we all are having these stress responses and a lot of uncertainty and unpredictability right now, that we need to acknowledge that there really is no better time for us to practice compassion and collective care, and that we are in this really critical time for self-reflection and inquiry. I'm hoping that I can share with you sort of the state of the science on ACEs and toxic stress. As a pediatrician and the researcher behind PEARLS with the fantastic team, I could talk about the science of ACEs for a really long time. I'm hoping to give you enough information so that we can then have a conversation about where do we go next in terms of policy. I will explain some of the implementation that's happening locally and across the state, and then just make some suggestions about where policy can go in order to support children and families, particularly now. So my broad vision as a pediatrician and leader in this space is to really transform pediatric healthcare so that we promote equity as a standard of care in an anti-racist and trauma-informed way in order to support the well-being of our children and families. Most of us on this call know what ACEs are. ACEs come from the original study that was conducted in the mid-1990s by the Center for Disease Control and Kaiser Permanente in San Diego that really focused on 10 questions in 3 main domains. And as we all know, those domains are abuse, neglect, and household challenges. The study was a landmark study because what it showed us is that there is a dose-dependent accumulation of stress and adversity that leads to poor outcomes. So in particularly for children that experience 4 or more ACEs, we know that they are at increased risk for poor health, ranging from higher rates of cancer, asthma, other pulmonary disease, greater risk for use of substances, higher rates of mental health concerns such as depression, and 32 times more likely to have learning and behavioral issues if their ACE score is 4 or more. We also know that within the state of California, that at least 60% of Californians have at least one ACE, and about 16% of Californians have experienced 4 or more ACEs. This is statewide prevalence data from the California Department of Public Health, Injury, and Violence Prevention. Although we have that statewide prevalence data, I just wanted to share with you some of the prevalence data from our safety net health centers. And these are safety net clinics that are now being incentivized to screen patients who have Medicaid, Medi-Cal for ACEs. And although I showed you the California prevalence, we have to realize that issues of poverty, issues of race, issues of structural inequities exacerbate and compound ACEs. And so, although the California state data suggests that 60% of Californians have at least one ACE, when I ask caregivers to report on the ACEs of their child within a safety net federally qualified health center, the average age of our children is about 5 to 6. What we found is that caregivers reported that 82% of those 5 to 6-year-olds already had 1 or more of the following exposures, and that over half had 4 or more of the following exposures. You see it's from this list of 10, and this list of 10 includes those original ACEs in addition to these social determinants of health questions. And so when we think about what is happening within our low-income families or our families of color, please recognize that ACEs can be exacerbated by structural inequities. The reason why this is so important is because what we are understanding is that toxic stress actually influences our physiology. It gets underneath our skin on a biologic level. We are not referring to positive stress, right? Positive stress is when I might have a test or I might be giving a lecture and I have brief increases in my heart rate, mild elevation in stress hormones. I take the test, it's over, I go back to my levels of homeostasis. Tolerable stress is more serious stress, but it's also temporary and it's buffered by safe, stable, supportive relationships. What we're understanding is that stress itself is on a spectrum, and toxic stress is the prolonged activation of our stress response in the absence of protective environments and safe, stable relationships. So more specifically, the statewide ACEs Aware initiative is using the definition of toxic stress that toxic stress is repeated or prolonged activation of a child's stress response without the buffering protections of trusted, nurturing caregivers and safe, stable environments that leads to long-term changes in the structure and functioning of the developing brain, metabolic, immune, neuroendocrine responses, and even the way DNA is read and transcribed. What this definition is suggesting is that early life adversity is balanced between predisposing vulnerabilities, protective factors that then lead to dysregulation of our endocrine system, our neurologic system, our immune system, and ultimately have clinical implications across the board, affecting the way in which our DNA is read. Those are epigenetic changes, affecting the way that our metabolism works, our cardiovascular systems, and our immune systems. A group of scientists, including scientists at UCSF Benioff Children's Hospital Oakland, the UCSF School of Medicine, the Center for Youth Wellness, decided that we were going to come together and really think more broadly about how we could screen for the original ACEs and also add in these other domains, this fourth domain for social determinants of health, into a prospective pediatric screening tool in order to be able to identify children early on in life to prevent, heal, and mitigate the long-term consequences of toxic stress. The way that we are defining these determinants of health are really the conditions in the environment in which people learn, play, work, worship, and thinking about how those factors are actually influencing health. We do have validated odd ratios for the initial categories of ACEs. We do not have those validated odds ratios in large population-based studies for determinants of health. And so at this point, we are understanding that there are associations between determinants of health and poor health outcomes, most likely induced by a toxic stress mechanism. I also want to underscore that racism causes stress, that racism really is a core determinant of health, that racism has been linked to birth disparities, it's been linked to mental health issues, and most likely is also linked to biologic mechanisms of toxic stress that can lead to increased and prolonged levels of stress hormones that affect us on a cellular level. This is the Pearl screen. I'm sure most of you guys have seen it, but let me just deconstruct it for you for a minute. And so you see part one. And part one are these initial 10 questions that are based upon the original ACEs questionnaire. And part two are these upstream factors, these determinants of health, these questions about community violence, about experiences of discrimination, about concerns about housing instability or food insecurity. We also have questions for teenagers, so once you are 12 and up, around if the teenager themselves has been incarcerated or detained, or if the teenager themselves is in a relationship that is violent. There is a huge role for the primary care physician in thinking about how we are supporting our communities and how we are screening our patients. really the role of the primary care physician is to learn the science and assess for toxic stress physiology and symptomatology, thinking about health conditions that are related to toxic stress, right? These health conditions range from asthma and allergies to increased headaches and stomach aches to ADHD. Our job is to provide trauma-informed care. It really is to address health concerns and manage these chronic conditions. Our job is to educate patients on stress management and then to help identify strengths and coping strategies that lead to resilience. The Office of the Surgeon General in California has put out a playbook for stress management that really focuses on 6 strategies in order to bust stress, right? Those 6 strategies are supportive relationships, encouraging physical activity, quality sleep, balanced nutrition, making sure that we are being attuned to our mental health, and practicing mindfulness. There is a bold call to action by the state, and that bold call to action is really to cut ACEs and toxic stress in half by 1 generation. If we are hoping to achieve, right, this really lofty, awesome goal, we do need to focus on not just the screening, but also what is the response to ACEs? What is that response in terms of providing basic income, in terms of providing childcare and paid family leave, in terms of supporting community-based organizations who are helping to address unmet basic needs like food concerns or inadequate housing, as well as supporting mental health in our communities. So we have this opportunity to really drive evidence-based, anti-racist, health equity promoting policies. And in order to do that, we have to consider organizational and practice change. We have to be able to eliminate structural and institutionalized barriers, to really think about developing innovative payment systems that reimburse providers not only for the screening, but also for the response, and help to create sustainability pathways to supporting more mental health. We also have to develop policies around data sharing analytics and how to make observations across systems that allow us to communicate and understand the impacts of stress on health. So I'm hoping this just gives you an opening to the conversation. I am here to answer questions, and I look forward to our Q&A. Thank you very much. I'm going to pass it back to you.
Thank you so much, Dr. Long. Presenting next will be Kimberly Chin from the California State Senate Health Committee.
Do you guys, okay, there we go. Hi, my name is Kim. I'm one of the committee consultants here in the Senate Health Committee, and my primary areas are in Medi-Cal, and so that includes coverage of kids in their Medi-Cal and all the kids-specific programs. I just wanted to talk a little bit here today, and more so in the Q&A as well, about what the process was for the committee this year, and some things to look forward to as we're heading into the next year. I think the first thing I'd say overall is that, as everyone understands, it was an incredibly unusual year, and it was really difficult to predict how it was going to be. And I suspect that it's going to continue like that next year as well. And what I mean by that is, you know, the legislature is typically very structured in terms of deadlines and process, and I think a lot of those were thrown off by the pandemic and how the committee handled bills this year. What ended up happening this year, as many folks know, was that we had to cancel a number of our initial hearings, retool the way that we did the work, and really hold all of the bill hearings in a very compacted time schedule. And that resulted in a lot of bills not necessarily moving this year. And the way that at least our committee worked on it was really asking members, senators, and assembly members to prioritize bills that either had an urgency this year or had a very clear COVID connection. And so those were the type of bills that we were moving forward. I think as for next year, I suspect there will be something similar to that. I think my colleagues on the call who will talk about the budget will also share that limitation as we move forward, the fiscal concerns as legislators and staff take a look at policies being proposed and the impact that it'll have on our systems. I think there's a tremendous amount of need right now, but I think we're really trying to balance the literal structure of the way that we do business in the legislature and the fiscal ability for the state to take on these new programs or not even new programs at this point, but to continue existing programs. In terms of bills and issues related to ACEs, I don't think there were a whole lot this year. There were a couple bills related to trans wellness. There was a couple of bills related to preventive screenings for kids, but nothing too, I don't think, too specific to ACEs screenings. But I don't know what that might mean for next year. So I'll just stop there and take questions later on and turn it over to you all to kind of pass it on to the next speaker.
Great, thank you so much, Kimberly. And just a reminder, everyone, if you have questions, place them in the chat and we'll get to them in a little while. Next, we will hear from Elisa Nguyen from the California State Senate Budget Committee, where she is the K-12 education consultant.
Hi, everybody. I'm Elisa Nguyen. For the Senate Committee on Budget, I cover childcare, K-12, and adult ed. And I will tell you, I've been in the education space for about 15 years and always focusing on state level policy and always focusing on funding and budgeting. So that's the perspective I come from. I'm excited to delve a little bit more into the health side because I think something that is much needed is this cross-referencing of our different areas. And I will tell you, you know, mental health of children, ACEs, that wasn't something that we talked about in the K-12 space. You know, when I first started in working on this, and, you know, we had some conversations honestly prior to the recession in 2008. And then when funds dried up, we really moved away from those proposals and just focused on survival. But as the state spent some time building out of the recession and transitioning to a new funding formula, you know, we looked at different ways to hold school systems accountable rather than just being based on test results. Our accountability system now includes multiple measures, including student engagement, including school climate. So just being more attentive to how schools are serving students and communities. And along with this, I think, came a growing awareness about the mental health of our students. And we started hearing a lot of reports on a regular basis on how teachers and school systems were really struggling to meet the needs of their students, and how, you know, mental health and other issues that students were bringing with them to school were really spilling over, you know, into the school space, and the system wasn't sure how to deal with this. Specifically in the Senate, we had a hearing in 2019 around mental health of students, and I think it was really eye-opening for our senators as, you know, folks from all parts of the state described the issues that they were facing and a lack of resources or lack of understanding about how to really tap into, you know, what was available on the health or community side. And there are good examples as well of this work happening. It's just kind of seems piecemeal and hit or miss. So I will say, you know, as we've had funding pre-COVID, we have been able to fund some specific programs in this area. And I'll just mention a few examples. One, over the past 5 years, we've funded multi-tiered systems of support in the K-12 system. And this was really a program to focus on training school districts to provide a tiered intervention approach to meeting students' needs. Whether it was behavioral health, things that they brought to school, whether they were the beginnings of maybe a need for special education, or really just academic issues, to make sure that the school system was considering the whole child and providing intervention at the appropriate point rather than waiting for issues to compound. Another thing I will provide as an example is out of that 2019 hearing and engaging with the Assembly and the governor, in the 1920 budget, we included funding for the Mental Health Student Services Act, which was a competitive grant program that provides some seed funding for school districts and other education entities to partner with their county mental health folks or county behavioral health to really draw resources together to support students in the school system and outside of the school system within the community. And this is something that, the Senate felt really strongly about, and we had hoped to continue this and provide additional funding for more cohorts, but particularly with COVID, that's kind of put on hold, although we do have those dollars, those initial dollars still moving toward this through the system. In preparation for this webinar, I went back and kind of looked at things. There are a lot of great resources that have been developed around trauma-informed schools for both students and educators. And like I said, when the system has funding, we're really able to focus some of those dollars on very targeted programs. But facing this coming year, it may not be looking like that. For 2021, the state received a lot of CARES Act funding from the federal government. A big portion of this goes into K-12 education, but that's one-time funding. And, depending on how revenues are looking coming into the next year, a lot of solutions we used to stabilize the budget currently. So coming out of this, K-12 alone is carrying payment deferrals of over $10 billion a year if we don't get some more federal resources. So, we're all kind of waiting to see how that works out, but wanted to address one of the questions that folks put to me for this. How do we continue to highlight some of these really important needs when we have limited resources? And so a couple of things, looking at past experience. One is seeking other fund sources, whether it's federal, whether it's community, and I know a lot of those things will be tapped into this year for many things. Another thing we can do is, do pilot programs and things that we can provide examples of to scale up in future years when that funding does come in. But what's more important, I think, for the very, very immediate needs we're seeing out of exacerbated by COVID that were already existing is figuring out how do we integrate these ideas and the ability to use funds for these needs into whatever programs we're putting forward. So I'll just provide one example. A lot of those CARES Act dollars that went into education went through the Learning Loss Mitigation Block Grant Fund, which was really intended to help to recover educational loss for students who are really impacted during this time, providing additional instruction or tutoring or what have you. But we also included language in there that talked about you can use these funds to provide more integrated pupil supports to address other barriers to learning. So including health, counseling, or mental health services, professional development for teachers, supporting of parents, access to school breakfast and lunch programs, which we just heard are contribute to trauma, and other programs specifically to address pupil trauma and social emotional learning. So I think that's a good example of when we have funds that are a broad use, calling these things out gives school districts more of a hook to say, hey, this is an allowable use of the funds, and this is the issue that we're seeing with our kids. So we need to use some of these fund sources for that particular issue. So I just wanted to throw that out as an idea as we move forward. We'll be looking for those examples and ways we can do that in the budget to make funds flexible. That's all I have for now, but I'm very happy to answer questions.
Thank you, Elisa. Next, we'll hear from Lena O'Rourke on behalf of Futures Without Violence for a federal perspective.
Thank you so much, Janice, and thank you everyone for the opportunity to talk to you here today. My name is Lena O'Rourke. I'm a consultant with Futures Without Violence, and I work on federal Medicaid policy. And my goal here today is to provide a little bit of a national context in what we're seeing in terms of states increasing access to trauma-informed care, but also some federal context in terms of what's happening in Congress and here in Washington as well. And it's super fun to sort of guess what Congress is going to do, but I can share a little bit about the environment and what we're seeing. I would like to acknowledge one of my colleagues, Kirsten Stewart's on the webinar as well. I encourage her to add or annotate me in the chat as well. And then once we get to Q&A, I can expand on all of this because I'm going to go pretty fast through all of this. So As we have heard from all of the speakers, we know that Medicaid, and in California, Medi-Cal, plays a big role in serving children and adolescents and paying for their behavioral health care needs. Specifically, though, just to level set, Medicaid can pay for trauma-informed care, and CMS has made this really clear through their guidance and then through the initiatives it has been supporting over the past couple of years. Over the past years, we have seen a number of states take advantage of this to really allow for the delivery of more specific trauma-informed services, but also to begin the transformation of state Medicaid programs to be more holistically and in a coordinated way addressing the impacts of trauma. So this has taken a lot of forms in lots of different states. And one of the most common ways we see this done is by leveraging the Children's Benefit Package, EPSDT, to explicitly cover trauma-informed care, evidence-based services, or specific types of practices. And we see that across the country in lots of different ways. More interesting, though, are some of the bigger systems changes. So, for example, New York has actually built a trauma-informed health home. And a health home is just a model of coordinating care that provides care coordination, case management, and enhanced services through the Medicaid program. New York's program puts as a condition of eligibility trauma and a risk of other conditions as a qualifying event to participate in this health home. So if you have this, you can begin to get an enhanced benefit package that addresses the trauma and the underlying conditions. It's an interesting program. It is brand new. In the first 15 months that it had been in place, the state saw 2,700 kids involved in it. So it'll be an interesting one to watch, and just a different sort of a model for addressing, well, in this case, complex trauma, but a different way of bringing enhanced services to bear. Also across the country, an interesting one is in North Carolina, where beginning in 2021, survivors of intimate partner violence, but also children exposed to violence and experiencing the symptoms of trauma in some parts of North Carolina will be able to get a new model of services through what's called the Healthy Opportunity Pilot. And it provides the children enrolled in this program with extra non-medical supports to address the underlying social determinants of health, and in this case, exposure to violence and experiencing the symptoms of trauma. So again, that program hasn't come online yet, but it is part of the system's transformative approach to thinking about how children and adolescents really, the role Medicaid plays in supporting children and adolescents throughout this. The last thing sort of on the state Medicaid side quickly is we have seen a lot of movement in states in terms of enhancing school-based Medicaid programs, and California has done this recently too. They recently made a change to be able, which allows the state to be able to bill more services to federal Medicaid with a real focus on behavioral health services. We've seen this in a number of states across the country. This focus on enhancing and strengthening school-based Medicaid programs, it is a financing mechanism. It's part of a larger system effort to braid together different funding streams, but it does allow Medi-Cal to play a stronger role in financing the delivery of certain behavioral health services. So we're watching that in California and across the country. Pivoting quickly and being mindful of the time, I know I'm moving quickly. I did want to talk a little bit about the federal context as well and what we may see from policymakers. Bit of a crapshoot on what the rest of this year will look like, and indeed what the rest of next year will look like and going forward. The election will have a big impact on Medicaid policy and going forward. But at the minute, we are really looking at the different ways we can support the delivery of healthcare services as part of the COVID packages that Congress is considering. In fact, yesterday, Speaker Pelosi released a new version of a COVID relief package. It's a slimmed back version of a bill she and the House had passed earlier this summer now, feels like ages ago. We're hopeful that the introduction of this bill will really invigorate talks. bipartisan, bicameral talks to bring another COVID relief package through the Congress and across the president's desk. Unclear what will happen there, but again, there's an awful lot of need to bring federal resources to bear. Of note for that bill, in addition to support to states for the Medicaid program, in addition to other healthcare supports, there is about $175 billion in the package Speaker Pelosi released yesterday that is dedicated for K-12 education that can be used for, among other things, providing school-based supports for impacted families, students, and staff, including counseling, mental health services, and family engagement services. And that money could be used for professional development for school-based staff on trauma-informed care to restore a learning environment. So some opportunities there were this bill and this package to move forward to really bring new federal resources to support the work we're all doing. Finally, I want to give a quick nod to a new piece of federal legislation that was recently introduced by Congresswoman Presley. It's the Strong Support for Children's Act, and it provides grants. Let me make sure I get this right. It provides 2 new grant programs administered through the Department of Health and Human Services to support local public health departments and community partners to address trauma and to ensure that trauma-related programming is available and accessible throughout states, regardless of immigration status, and really acknowledging and being responsive to healing-centered, neighborhood-based, gender-responsive, culturally specific, and trauma-informed approaches. So this is a relatively new effort, and one we'll be watching and supporting as we try to find individual pieces of legislation that will really divert resources into the types of programming that will make a difference. So with that, I covered a lot and went a little too long, but Janice, I will turn it back to you and I'm happy to answer questions.
Great, thanks. No, it was perfect. Thanks so much. Next, we will hear from our final speaker, Erin Gable from the California State Assembly Budget Committee, where she is the K-12 education consultant.
Hello, thank you so much for having me on. So my name is Erin Gable, and I'm a consultant for the Assembly Budget Committee and work for Assemblymember Phil Ting, where I cover our early childhood education and K-12 public education issues. And having spent most of my career as a public education policy generalist, I actually, most relevantly to your issues, just rejoined the Capitol team this March after a 5-year tenure working as the deputy director for First 5 California, where I had the incredible experience as having spent most of my career in the K-12 silo, really seeing how you all have been working in the early childhood space very successfully in recent years to try to break down these silos and to think about what we like to think of as what children bring to school with them besides their backpack that impacts their ability to learn and to thrive. So that's a little bit of background about me. In fact, I had the wonderful privilege of hearing Dr. Long speak a number of times, so I was saddened to not be able to hear her today since I had to join late, but I'm sure it was very inspiring, as it always is. So, and also thank you to my counterpart, Elisa, for giving a great K-12 education context. There has been incredible progress in the last decade on starting to think about trauma and a student-centered approach to public education, mostly because of incredible examples that have been happening despite the silos at the local level. And the innovations we continue to see successfully pushed forward at the local level, even though we're still trying to get our state catalysts and drivers into place. In addition to the incredible achievements that Elisa had been talking about, I think that the whole concept of the local control formula and the idea that we need to be taking a student-centered approach to thinking about the social determinants of learning, the social determinants of the achievement gap, are a huge sea change for public education and give a lot of opportunity, despite the funding silos and the policy silos you see, opportunities in this world. And so, thank you to all of you for being silo busters and great advocates. I know we have a long way to go, but we did have some great temporary successes in this year's budget, both because of and despite of COVID, that I know both Lisa and I had wanted to highlight. And one of those is the achievement of investment in community schools. So in this year's budget act, at the request of the governor, there was a recognition of the importance of our community schools and how expensive it is, as receiving funding through Medi-Cal, through our county health department still eludes many community schools models and LEAs. And so you saw an investment in our existing community schools, hoping to see them, hoping to help them weather this COVID period where they're more important than ever. But we know that many of their school-based sponsors will be having really hard choices in front of them during a recessionary period. And so for those of you who are currently engaged in community school support at the local level, hopefully you'll be able to work with your champions and your leaders to make sure you access those funds that'll be available over a 5-year period to stabilize your programs and hopefully expand them for those students who need them the most and who were experiencing trauma before COVID, and now that population is just growing and needing more. In addition to that, we were able to secure for the first time a meal reimbursement for California's summer meal program. So as many of you know, summer meals can be one of the few healthy meals that children receive during the day while they're potentially home alone for great periods of time. We were able to pilot that this year with a 75-cent per meal summer meal reimbursement, and saw an incredible number of school districts that normally would not have served summer meals step up to the plate both during the COVID closure period and over the summer to make sure that kids received access to that incredibly important meal or package of meals that they were able to receive over multiple days. And I think that we are very hopeful that with local advocacy, we'll be able to see school districts that were able to make it work during this summer will be incentivized to continue those programs and to see the worth of them despite the cost. Also in the context of COVID, there were two really important pieces linked to trauma during this historic time that we're hoping you all are keeping an eye on in your school districts. And one is the requirement for daily live interaction. This requirement was intended to ensure that every child, because we had so many students who were falling through the cracks during the spring, and we were seeing historically low mandatory reporter rates of abuse that we normally see just during normal times of trauma, not including the fact that shelter in place and COVID is creating an incredible burden on children and families, pushing us all. that we wanted to make sure that that caring adult live contact was happening every day, even in a virtual learning environment. That was really crucial, and that the live peer contact was happening every day, so that not only the students were receiving support, but that also that necessary, the idea that that caring adult is there was reflected in our minimum standards during these crazy times. We also were very encouraged to encapsulate this idea of tiered re-engagement for those students who are falling through the cracks and whom distance learning may be failing, making them a priority for being brought back onto campus safely for in-person instruction. And while how that in-person engagement and how tiered engagement may be defined is done at the local level, that gives you all as advocates and as leaders the ability to really think long-term about how you want tiered engagement to continue to look like for your chronic absence children, for students who are disengaged for a myriad of reasons that may have nothing to do with academics. And so we're hoping that that actually helps to build upon some of the best practices you all have launched. And then last but not least, we were very encouraged to continue to expand access to early childhood education and childcare during these incredibly hard times. It has been a point of stress for our childcare workers to be open during these horrible times, to be considered an essential service. But despite the trauma and the stress that it has been across the board, it was incredibly important for the legislature to recognize the importance that that second teacher or first teacher in a young child's life, how important maintaining that bond was, including a hold harmless for those providers if the family continues to shelter in place. And so we're hoping to see that essential part of our workforce continue to survive these very turbulent times, as they're an incredible buffer against ACEs and against trauma for the children who are in their care. So with that, like my other counterparts, looking forward to the Q&A and discussion later.
Great. Thank you so much, Erin, and everybody. Really just so much appreciate your comments and your engagement issues that are really critical to our state moving forward. I am amazed by all the wonderful questions coming in here. And so I have some questions to start us off, but then really want to dive straight into those. And I've given Janice a link to a Google Doc with all these great questions in them, so she can start going through and getting ready to ask them. But first, I have a few things that I wanted to ask. Kim, and if all of the speakers could come on video if it's convenient and you don't have a child tugging on you or anything else at the moment, that would be great. Kim mentioned a bit about, and all of you in the legislature, about the limited schedule due to COVID this year, and really how just a few bills were able to get through. And there was a lot of critical legislation that went forward. Just wondered if the three of you in the legislature could comment a little on the dynamics within the legislature this year, and any suggestions that you have for our eager advocates around what they can do to move things forward in the coming year, knowing that no one has a crystal ball and knows what's going to be happening, but any idea package legislation or how to think about what we're working on really help us going. And Kim, Erin, Elisa, I don't know if one of you wants to take that on. I know it's a big question.
Sure, I can start. Budget's a little bit different than the regular bill process, and that we still have to do it. We can't limit, not that we have that many bills. We have a couple rather large bills. This year we did limit, individual member requests, so things that were, specific to one district over another, unless they were really, really necessary. So I think going forward, that will be true next year as well, that we really need to focus on statewide impact and how we can leverage funds across the state. And then we honestly, just because of the changing dynamics, focused a lot on how do we respond to very immediate needs. Hopefully next year we'll have a little more time to, think a little more long-term, but a lot of it was just, moving fast and responding to the changing dynamic and situation for schools. And then, like I said, I think we're all gonna have to be mindful of the funding picture this year and how we can, do our best to make funding flexible to meet needs, given that the severe limitations we may face. I don't know if Erin, if you.
No, I think that you said it greatly said. The only thing I would add is, because we've had the ability to make a few key investments, both because of and despite of COVID, that we really are also in a test period of what limited but crucial catalytic funds have been provided at the local level. And so continuing to communicate the successes or the learnings and the import of those investments, especially right now where we're probably going to be in a protectionist mode for what limited funds we do have, and in a local control funding context, I think that's going to be more important than ever. So to keep those feedback loops about what is happening around community schools during these times, what is happening with the safety net and hierarchy of need programs that you're supporting for kids, and how they all interact, and to not let those issues go.
Yeah, and just to expand a little bit on what I was talking about earlier in terms of the bill process, I think it was unusual for the Senate this year to not hear all the bills that were sent over. That's not something we usually do. And the directive that was provided to members was to really prioritize things that were immediate and urgent for this year or had a clear COVID connection, really encouraging folks to come back next year on those other issues. And so now we're going to kind of transition into next year. And I think if I really think about if anything has really substantially changed in terms of our space and capacity to do things, it hasn't. And so I'm also really curious as to how folks are going to be able to balance that, because now you're going to have things carried over from last year folks that didn't work on, and then all the new things that come up. And I think what I think many folks have begun to see is how much things have moved online. And I think that the stress that puts on just the IT process, like really going into the nitty gritty here, is that our IT staff was working 7 days a week in order to make these hearings happen. And so that's like one of the key limiting factors for this, is just the physical space that we have to do this is not there. So that said, I think we, for an institution that can be bureaucratic and move slowly, I think we transform fairly quickly to accommodate some of these things. I think maybe slower than folks like, but I think definitely change. So I am curious as to how we're going to handle that, since so many folks were asked to kind of hold off on their ideas until next year. And well, I guess we're gonna have those ideas come back then.
Right. That's so important, and really great to point out the IT, which I feel like more and more, I'm dealing with on the other side of this panel, the IT child and my own, and just hard to imagine having that happen for 120 legislators and all those different committees. So I think it was Christian Griffiths, who's one of your bosses and the budget committee, Erin. He tweeted something like, if something's not in the body of an email, I'm not looking at it. And that was really helpful for me, just to remind me, I realize that everyone's busy, and as an advocate, I interact with legislative staff, I assume they're way too busy. But to think of the brass tacks of it, to, copy something into the body of an email and make it just as easy as possible, both to respond, but also to draw the connections for them, so they don't have to work hard to see the connection to COVID, or to why this is so important right now, or how this helps kids. That nobody has to work hard to make that happen on the legislative side of things, I think is really our job as advocates. So just a good reminder to me, as always. I wanted to ask, kind of circling back to the beginning with Dr. Long and the screenings discussion. Dr. Long and other folks, please chime in if you, what is the future? So we've got these great screenings. We've got the pearls happening. We've got screening happening. I, as a research and data person, would really like to see numbers about what's going on, de-identified, of course, but to try to get a sense of what's going on. But what's the future here? Sort of, as you pointed to, Dr. Long, we want to get beyond, the screening is a critical and important first part, but we want to get beyond it to connect people to services. Do you see that happening in this immediate future?
Thank you, Kelly, for the question. And I think that this webinar is really helpful, especially that we have a full spectrum of panelists who can speak to what's happening on the ground and then what's happening at the Capitol. So be aware that this legislation for the incentive was live as of January. That providers were required to attest in order to draw down on that incentive to implement screening as of July. And so we are 6 months in, and COVID happened. And so what we have found remarkably is that almost 15,000 people, 15,000 providers in the state of California have taken the training. And so that's huge just within 6 months. There are numerous initiatives that are supporting the implementation across the state. Some of these initiatives are programs that the ACEs Aware statewide is supporting, and other initiatives are through the American Academy of Pediatrics or local provider networks. And so I think that the broad goal is to make universal screening a standard of care during well checks every year up to the age of 21, and then thereafter for adult providers to screen adults at least once in their lifetime. And I would love to see us, a year from now, being able to say that every single provider in the state of California has taken the training. Every single provider is on the process to implementing universal screening, whether that is doing education and engagement around trauma-informed care and cultural humility, to actually teaching the providers how to deliver anticipatory guidance around stress. The next step certainly is the response. And that response, a lot of it includes providers understanding that oftentimes we don't feel as if we're good enough, right? There often is this notion that we have as doctors that we have to fix everything. And part of what trauma-informed care is teaching us is that oftentimes having empathy, listening as if your whole ear is a body, and being there and actually seeing our patients, oftentimes that is what is being called upon. And that is a huge shift for us as providers, right? And when a family screens positive for food insecurity, or we need to refer them to community-based mental health resources, we definitely need to create these networks of care so that there's multi-directionality, so that we can refer to the food banks, so that the food banks can follow up with the family, so that we know that that resource need was resolved, at least for the time being, and that we don't reach saturation points, such that if families who are on Medi-Cal insurance need mental health resources, that there is a plethora of community-based specialists that we can refer to. And so it's a tiered approach, right? The universal base is that everybody is screened. And then the next tier up is that those that need to get connected to resources, those resources are readily available, and they're available in a way that allows for all the directions of the communication that are necessary. And then the top tier is really those specialists and making sure that our communities have access to them when necessary.
Kelly, can I layer on?
Please.
And Dr. Long gave me a great platform here in Virginia, so if it gets real loud, I apologize. One of the things we are looking at is how to build that network of community-based providers and to build the relationships between the medical providers and the community-based providers, the children's advocates, the domestic violence advocates, the promotoras, the community health workers who can and do now provide a lot of the services that Dr. Long just spoke to. And clearly, one of the foundational pieces we need to solve for, and we're seeing a lot of interest in talking about, is how to get those community-based providers paid for doing some of the services. They're stretched beyond capacity and need the resources for the services they're already doing, but so that they can be there when Dr. Long and her colleagues need them. I think also, and we're seeing that conversation about being paid, how to pay these advocates. It's something we've really been thinking about a lot. And we're getting closer, I think, to figuring out how to really leverage Medicaid in practice to do that. The other piece, and maybe this is a silver lining about COVID, is how to build the technology so that it's not a handout, it's a real warm referral system that addresses both real-time capacity and appropriate matching of services so that the healthcare providers know who is available to help and the resources available. And technology can solve for a lot of that. But it needs to be done in such a way to respect the privacy and confidentiality of both the patient and the families. It needs to really be detailed enough to match the services appropriately. And I mean, this is where I get out of my scope a little bit, but acknowledge that there needs to be some sort of feedback and referral loop so that the parties all know what's happening for a holistic system of care. And we see that. I mean, this North Carolina pilot that I mentioned before, that's the goal, is to build this sort of coordinated network of community-based organizations who can provide these non-medical supports. And it's an interesting model. I'm not sure it's the only or the best way to do it, but I think different states are doing it differently, but I think increasingly we see the role of Medicaid and Medi-Cal in their ability to do this and to get these providers reimbursed for. So it's a challenge, I know, but I think we're on that path, which solves the other side of the equation, I think, or at least a piece of the equation that Dr. Long laid out.
So I just want to add one thing, Lena, and it's very important that we remain grounded in the science and that we understand where the evidence and the data are taking us. And what we do know is true about ACEs is that the biggest protective factor against poor health outcomes associated with the accumulation of ACEs is safe, stable relationships and environments. And thinking about what it means for parents to be that buffer. What are the skills, what are the capacities, what are the resources that parents need in order to buffer, recognizing that stress is often caused by structural inequities. And so I think that as long as we remain grounded in the science and understand that the intentionality between making sure that families are not food insecure or that they don't have unstable housing and that they have childcare, is that you're buffering that caregiver to be the very best caregiver that then they can be for the child. We have recently discovered evidence within the population of kids we are studying as part of the Pearl study that demonstrates that caregiver reported stress is directly linked to the physiology of stress dysregulation in their child. And so that the amount of stress that a caregiver reports that they're under is actually manifesting in the body of their child, which I think is fascinating and really important to hold on to.
That's so helpful, Lena and Dr. Long, thank you. And I think we want to continue to bring it back to, trauma and stress are not affecting all of us or all of our kids the same. And the real anti-racist center of this work. So I appreciate that.
Kelly,
Lena,
I just want to let you know, I think that was Elisa who, she's coming back.
Okay, great. Lena, I'm stealing a question from Sarah Rock. Thank you, Sarah. In follow-up to, you had asked about, you had been talking about how the referrals for services can be covered by Medicaid. And Sarah's question was really around, can they be reimbursed through MA or TCM, which I believe is Medi-Cal administrative activities and targeted case management? Or what is I get the sense that there are many routes for reimbursement, and it takes a skilled Medicaid navigator to be able to get these referrals reimbursed. But I want you to expound on that, please. And
Absolutely. Well, I mean, absolutely. I'm happy to address the question. I'm not sure I can answer it because, Kelly, to your point, I mean, Medicaid's a tricky one. And there are lots of different paths for reimbursement. And this is where I have to admit that I don't know California's reimbursement system well enough to really address it. I will say, though, that sort of broadly, depending on what the state plan covers, and particularly for children and adolescents under EPSDT, there is a range of services that can be covered, including some preventive, including some care coordination that I think falls under this bucket. I mean, certainly TCM and care management they're all reimbursable services. I think maybe the intent of this question gets a little bit more at how and where different types of community-based providers can seek the reimbursement. And that ends up being, a function of who is an eligible provider under Medi-Cal, and the different types of providers, or what type of arrangements do the providers have, or excuse me, the community-based providers have, and kind of partnerships do they have with other types of medical delivery systems. So for example, partnerships with hospitals or community-based health centers, where often we see community health workers and working in partnership and expanding the reach of the health center outside of the four walls of the community health center. So Sarah, I don't think I can directly answer your question. I think I'll just say, and maybe others can point to more specifics, that I do believe these type of partnerships and reimbursement arrangements are reimbursable. I think states are experimenting with them. I think it's in the nascent stages of it, but that I'm optimistic that there are ways to fold them in, and both now and in the future, we'll figure out those pathways more clearly. And I just don't know.
Thank you.
And if I could,
yes,
yeah,
please,
I was gonna jump in a little bit here. I mean, I think everything pre-COVID, right? With the CalAIM proposal, there was some discussion in trying to begin to organize and make sense of how TCM and all of those things work together, and those, I don't recall off the top of my head, but there was a real effort there to really make care coordination, enhanced care services, right? All of those things make a lot more sense. And unfortunately, we're going to have to see what pieces of those proposals get picked up. And I think, Kelly, you could talk more. I can, you and others at children's groups, we're trying to really engage with the department on exactly how kids were going to be wrapped in these conversations. And I don't recall we ever really got a clear answer from them of exactly how they were going to fit all those pieces in. And of course, there's always a standing issue of billing the school-based billing and getting CDE and DHCS to work, and it's sort of a perpetual. We're working on it. We're going to talk about it, and then there's a bill, and the bill gets vetoed, and so it's just so. It seems like there is beginning to be some traction in conversation. At least that was my feeling last year, that there was a greater willingness on behalf of DHCS to provide more specific TA to schools that we're trying to do the right thing on this, right? Those who truly trying to provide that care coordination. But again, as is sort of becoming a theme, some of those conversations I suspect have stalled given the all hands on deck nature of COVID. Yeah.
Thank you. And that overarching theme of collaboration between CD and DHCS generally, and between health and education even more broadly, I think is so critical. So thanks for bringing that out. Next, I'm going to kick it over to Janice. We got so many great questions, and I don't know if we're going to be able to cover them all, but we will be on till 12:30 attempting, and with those speakers who can stay with us for that whole time. And if you can't, just message me and we'll do the best we can. Some of the questions did get answered in chat, so take a look there if it was something very sort of quick and specific. And Janice, I'm passing it off to you, my friend.
Thank you. And actually, I want to just kind of go back to the last question. We saw so much more conversation pre-COVID about integration of services. There just was a much bigger, much broader interest in trying to collaborate across disciplines to strengthen families. And I noticed really in the last maybe 2 years that conversation had really shifted to thinking about how to integrate services and how to break down silos in more than just sort of a lip servicey way. So I was really encouraged by that, and hopefully, you know, post-COVID, we'll be able to go back to some of that really great work. One of the questions I wanted to ask that got raised in the chat has to do with, for Dr. Long, about the generational trauma factor, and how does it impact children and perpetuate into future generations? Dr. Long, if you're able to talk a little bit about epigenetics today, that would be great.
Yes, so we do know that trauma is historical and that it can be passed from one generation to the next. We often know that children's ACE scores mirror those of their parents or caregivers. We are hoping that as a result of starting to screen early, so annually from 1 year of life and beyond, that we'll be able to break this intergenerational transmission of trauma. Recognizing that, you know, my colleagues in family medicine, intern, and OBGYN are also, the way that trauma gets our skin is multifactorial. One of the ways that trauma gets underneath our skin is through not altering the way DNA is paired together, but by altering the way in which DNA is actually read. And these types of changes are known as epigenetic changes, right? It can put a cap on a piece of DNA, that's called methylation. It can skip over a section of DNA, and then what happens is all of a sudden you start coding proteins, and those proteins sort of flip the switch. They flip the switch on coding for cancer, or for asthma, or for diabetes, or for hypertension, or for other forms of mental health concerns. We do know that these epigenetic changes then can get passed down to the next generation. Our hope is that now that we know these switches can flip on, that we are able then to flip the switches off through practices of mindfulness, through practices of realigning sort of homeostasis on a biologic level. There's a lot of great articles about genes and the environment that I can share with the panel for folks that want to learn more.
Great. There are a number of things coming up about resources and contact information for some of the programs that were referenced. So I think we'll just ask all speakers to, if you've made reference to some other program that you can help us link to, maybe we can put that out in the follow-up. Here's another question regarding state funding for mental health in schools. Every metric points to the connection, here's the background, but really they're asking about social emotional health, student success and well-being, and how LEAs can secure funding for mental health presence in schools. And they're really pointing out that the grants go away and committed dollars are really needed. So that's, I think, best for the education staff.
Elisa, I don't know if you were still there. I know this was a big issue for you and a big achievement last year. I know her internet's been a little weird.
I'm here. I don't know. Can you guys hear me?
Yeah, it's perfect.
Okay, let me know if it gets weird.
No, it's great.
Yeah, I think we really recognize that, you know, grants only go so far. They're one-time funding. That was a huge concern with us. The amount of funding we're able to put out is not huge. It's not going to cover the need. But the real point of at least those mental health services, Mental Health Student Services Act funding was, we know that there's funding on the health side and schools cannot bear the entire cost of this, nor do mental health issues, you know, only occur during the school day. And so the point was to help tap into broader systems of care to help support that effort. So if you look at the language around that act, it's a little bit of funding, but it talks about being able to, you know, triage and help a student in crisis, but also hand them off to their private insurance to, you know, other public health resources? How do we create a pipeline for them to get services long term, so that we're trying to think about sustainability. Again, they were very beginning efforts of this push, and I think multiple folks have talked about trying to also help schools tap into other sources of health funding and how they do medical billing and such. So I don't know if Erin wants to add any more to that, but
yeah, no, absolutely. And just to piggyback on what Elisa was saying, in addition to the one-time funding the legislature was able to secure last year, it sparked there being a K-12 subgroup, a K-12 policy subgroup for the Mental Health Services Act Oversight Committee. So when you think about what comes next, engaging with that subcommittee, who, by the way, right now is not including ECE in their purview, and I'm sure you would all giggle to hear that because that seems very silly. But anyway, so how are we thinking about building on the seeds that were planted with last year's investment? How are we going to build on the community schools seeds that will be invested? And I saw a question on that. There'll be an RFP coming out from CDE on that. We know these are not sustainable funding sources, that healthcare dollars really are the sustainable matching healthcare supports for our underfunded schools. I know when you think about the enormity of Prop 98, people think that it's this huge pot of money that should be tapped for everything, but really, truly, our schools continue to be some of the most underfunded in the state, in the country and in the world. So we need to think about comprehensive services coming from other sustainable sources. So the more we can all work together to follow up on these seeds, the better I think we're going to be. So I would encourage folks to the point Lisa was making, to really buckle down with the commission and make sure that we're leveraging the mental health services funding streams that we have more effectively.
So just speaking from a very tiny, sort of very nerdy section on the healthcare side, and picking up where Erin and Elisa left off, Medicaid does pay for certain services in the school-based healthcare setting. And earlier, still 2020, earlier this year, California received permission to bill for more services that are delivered in schools. Previously, you could only bill for services that were in a student's IEP. And now federal Medicaid reimbursement is allowed for services to all Medi-Cal enrolled kids that get federal funding delivered by the eligible providers. So this is not a silver bullet. I think it layers on top of what Erin was just saying in terms of needing to braid together the sustainable funding sources. But this little light switch that got flipped for school systems, for LEAs that are participating in the LEA BOP program, it allows them to build more services for more kids, which means more federal reimbursement coming back to the state and to the LEAs. And I know it's a difficult system, but as we look for every possible resource, this one has real potential to bring down more federal resources. And at Futures, we've really been thinking about this in the lens of, okay, so how do we do that in a way that really helps us focus on behavioral health and on trauma-informed care? And I think there's a lot of leverage in terms of the providers and the services that are delivered to really do that. So again, not a silver bullet, but one more way, one more stream of sustainable funding for more kids that can come into the schools.
Great, thank you. I think that's really helpful. There's a question here for Erin and Elisa as well. Can you comment on the implementation of the daily live interaction rule and help us get sort of an understanding of how many districts or what percentage of students are receiving that?
Yeah, that's a great question. Thank you for bringing it off of the chat. So the concept of daily live interaction is a minimum standard for any school district under distance learning. So if the schools are currently closed due to COVID and the schools have moved to a distance learning model, they are mandated to have daily live interaction happening with each of their students, with their instructor or certificated instructor, and their peers. So there's no minimum number of minutes associated with that. but it is meant to be a daily interaction, and then that interaction has been further defined by the Department of Education if folks have any questions about the minutia of how that might be measured.
Great. I think we'll just kind of switch gears a little bit to answer some of the other questions that are here. I think this is an interesting question, maybe for Dr. Long and others, about how schools regard mental health support without having to pathologize the student in order to access funds. This is also a Medicaid question. You know, how do we get the language changed so that it's not a barrier to reimbursement, so that we're not handing diagnoses in a way that is inconsistent or unfair based on race.
So I think you're getting at how do you create diagnostic codes in order to get children's services. And what we are doing both within our primary care clinic as well as the school-based health centers that we run is that when we screen for pearls and it looks like there's increased levels of adversity that could lead to stress that can certainly the accumulation cause mental health concerns. We actually are using these G codes from the state to bill for the Pearl screen, and then we're using ICD-10 codes. For instance, we're using the code for stress, which is just a general diagnostic code that doesn't necessarily require a diagnosis to be labeled onto the patient or the child. I hear what you're saying. Our healthcare system is very much based upon diagnostic codes, and what we're learning is that stress accumulates and that it is a normal physiologic response to untenable situations, and it's something that we still need to work on. But for the time being, we are using ICD-10 codes such as family stress, and there also are ICD-10 codes for the social determinants of health questions, such as food insecurity or housing instability.
Great, that's really helpful. I think there are a few other questions here that I think would be worth asking today. One is about public awareness, and are there any public health organizations working on a new kind of parenting education? Perhaps multimedia messaging that teaches parents behaviors and practices generally recognized as supporting the healthy development of children. I know we've all been involved in trying to raise public awareness, but if any of the panelists have any answers about that, that might also be for you, Dr. Long.
So within a clinical space, I will say that we are destigmatizing screening. And so part of it is around our messaging that stress affects, excuse my dog, that stress impacts everybody, that we are asking everyone these questions, that this is our standard practice is really helpful so that parents don't feel like they are being targeted. We also, in the anticipatory guidance that we are delivering, we also make it known that stress impacts our hearts, our minds, and our bodies. And that the child is actually having an adaptive, normal response to a maladaptive circumstance. And so I think a lot of it is just in how we handle sort of not what is wrong with your child, but what is happening to your child.
Right, right.
And I don't know if this got covered before I was able to jump on late, but I know, sorry guys. What I was saying is I know that that the Surgeon General's office, and I know we're all so excited about what it means to have a Surgeon General of California, you know, that she was funded to have a comprehensive ACEs public engagement campaign. And I'm not sure where that is in the implementation phase, but for those of you who are not directly engaged with her office on that, I would encourage you to, because it is intended to have a multifaceted approach.
Right. Here's another question for the education folks probably, and I know I've run into this as well, about the digital divide and how it impacts rural students specifically. I think it's just a really interesting question. We were trying to design legislation before the end of the session that would address services in rural areas, and just trying to understand what their needs are versus children in urban settings. You know, how do we reach them? How is the internet getting to them? Kind of, and how do we bridge that divide for them as well?
Maybe I'll jump in first. I know Lisa will have more to add. You know, the digital divide is now probably one of the biggest inequity makers in our modern society because of COVID, in that you can't access telehealth without internet. You can't apply for unemployment insurance if the system were to be back online without internet. You can't access your free and public education without internet. You know, folks are sheltering in place and doing their best. And so the inequities of our society are being just further perpetuated. And it's not just a rural issue. It's also happening in many of our urban communities, Wilson and Fresno and others. So, you know, how we address internet access as a fundamental utility opposed to something that's the responsibility of one sector or another, I think is a really fundamental public conversation we have to have. In the absence of having done that, you know, digital access to whatever the platform is for public education this year is another one of those minimum standards for distance learning. So if distance learning has a digital platform, the school district is responsible to make sure every child has access to it. That was a huge thing to put on our rural communities, and we know it. It was hard to swallow, but we did see it as an important minimum standard in terms of equity. So all that being said, we know that many of our LEAs and our communities are still struggling with this minimum standard, and they're struggling with it because it's a societal challenge. You know, with both hardware and software, and you know, everything in between. And so I think that if nothing else comes out of this year in the learnings of COVID, we've got to figure out, once again, silo busting. How do we ensure equitable access to this basic utility so that folks have access to the same society?
Thanks. Okay.
And I'll just add that.
Go ahead.
Oh,
no, please.
I'll just add a couple things. One, I feel like, you know, Erin highlights all those problems that exist. We tried to do, put Band-Aids on and do a patchwork this year to get through this school year. So, you know, the distribution of devices and hotspots, but they are not, you know, they don't work for everybody. We've also provided, the state's provided the ability for school districts, even if they're, you know, not in the, you know, in the red tier yet, to bring back small groups of students of, you know, particular needs, whether it's special ed English learner or because they don't have access to be able to do distance learning. So there's a patchwork out there to try to help folks deal with this, knowing that we cannot fix it all immediately. So throw that out there, not perfect, but working on it.
Great, thank you.
And if I could just add that, sorry.
Yeah, go ahead.
Sometimes we don't see alerts and issue areas that aren't ours, but the Assembly Education and Communications Policy Committees are going to have a joint hearing on October 14th on exactly this issue. So for those folks who are concerned about it, I would encourage you to tune in.
Great. I have one more question I think I'll pull up from the chat. Can 0 to 5 home visitors or paraprofessionals be trained and certified to implement pearls with families? And is there a way for that to be billable?
So I want to refer everyone to our ACEs Aware website, www.acesaware.org, and you can go on and click under training, and there's an online training that's open to everybody. There also are a number of webinars that are on that site. In terms of billable, my understanding is at this point that the Pearl screen needs to happen within the context of a medical visit within a clinical setting. And I think that there are discussions about how to expand it potentially, but right now the billing is by a provider within the context of a medical visit.
Great, thank you. And I think with that, I'll turn it over to Kelly, and she's gonna just close this out for today. But I really enjoyed listening to all of you, so thank you for being here.
Great, thank you so much, Janice, and thanks to all of our speakers. Really learned a lot from you today, and I think we were meaning for this to be a forward-looking. There's a lot to be worried and scared about right now, and meaning for this to really be forward-looking and see, you know, what can we be doing moving forward, and I think that you all really delivered that. So bravo to our speakers. I think the emphasis on working across the silos and in making sure that we've really listened to what kids and families are saying and what they're telling us. You know, the messages are very clear about supports that are needed, and our job as working across all of these different types of organizations and positions is really to follow their lead and to follow up on that. Thank you all very much. We're going to send around the recording when we get a chance. We're going to send around slides, and we'll follow up with folks who had questions. And again, just thanks, and look forward to continuing to work with you all. Goodbye.
Thank you.